My name is Jinket, JK. I'm a counselor, been practicing for a while. Today, I will be sharing with you about suicide and self-harm, effective strategies for interventions. And we will cover the topic, the definitions. We try to understand a bit more about suicide and self-harm. Then we will continue with to discuss some of the strategies. Okay, right. I want to put a disclaimer here. Throughout the sessions, if you do feel overwhelmed or you don't feel comfortable, you can just choose to withdraw yourself. Just take some breath, fresh air. You don't have to ask for permissions. You can just leave the hall to do what you think is best for you, right? And that don't worry about that part. I just want to put a disclaimer out there first. Okay, right. We will talk about self-harm, misconceptions of it. We will also discuss some approaches. Now, as I'm aware that we are talking to students, counselors, and clinical psychologists, so I will try to put in some disclaimer here and there about things that we need to be mindful when we are approaching for we are discussing self-harm, right? And to talk about how to support people with who are struggling with self-harm and understand what is self-harm behaviors. And if you do feel triggered or that overwhelmed, please do also after the sessions reach out to any professionals, any friends to discuss, and that if needed, reach out to your IMU self-development unit, right? Or outside counselor of your choice if you do feel overwhelmed after these sharing sessions. Right. We talk about self-harm, right? Self-injury in some of the context, right? As we describe it as a range of behavior that people do to themselves deliberately, and that it remains a secretive behavior can go on for a long time without being discovered. Right. In this context, we try to understand self-harm involve cutting, burning, punching, inserting or swallowing objects, right? And that head banging, hair pulling, overdosing, restrictive or binge eating. And it's important when we talk about suicide in this context, right? We are discussing self-harm and suicide together because there are studies indicating the associations between self-harm and suicide. And that later on, I will also touch a bit upon about where how they try to understand if, let's say, a person been conducting or that carry out the behavior of self-harm to a certain degree, it increased to even sevenfold to tenfold of the likelihood of an attempt. And of course, when we talk about the association, we are still discussing in the context of self-harm as well as suicide. There are still many factors for us to consider. It's not like, okay, wow, if you do carry out self-harm, then it's definitely you are suicidal. We are not talking about that because there are many factors for us to consider. However, it is very important for us to be aware if your clients that you are seeing is having self-harm behavior. And to what extent we might have to prompt or explore or even to certain contexts evaluate comprehensively. Why I will share a bit more about the needs for that. Now, self-injury, right? Any behavior that causes harm or injury to someone as a way to deal with difficult emotion can be seen as self-harm, and that self-harm is not a suicide attempt or cry for attention, which can be a way for some people to cope with overwhelming or distressing thoughts or feelings, and self-harm should be taken seriously. In the context of school, self-harm is in most schools who have child protections and safeguarding policy, self-harm is being viewed as a highest regards priorities to deal with immediately. They see it as serious as bullying as well as suicide attempts or suicidal ideation if we are looking at active, high frequency, intense or suicidal ideation, right? And so because of this, when in the context of school, self-harm is something that counselors or mental health professionals in certain school policies has to evaluate in a more holistic manner. So, what is self-harm? The cutting, the caving, the scratching of skins. That you can see some clients that will scratch their skins until it bleeds in a way to cope, and cutting, and to even uh, in today's in terms of they're trying to understand a bit more in terms of self-harm, right? Because it's ongoing exploration about the concepts of self-harm. Some scholars are pushing to understand if over exercising is a form of self-harm. But of course, it's debatable at this point, right? Because it's normalizing, as well as that people who struggle with over exercise can be understood as okay, it's a common behavior, or that is normalized, that it doesn't view as a self-harm category at this point. But there are scholars who are proposing that because over-exercising also strongly associated with eating disorders or that struggle with eating. And so when we look at self-harm, we talk about deliberate private act. We talk about it is not attention seeking. It's not meant to be manipulative. In other words, there is stigma there. There is how people view self-harm could be. And when we work with clients, they might come in with that they know maybe it's self-harm, but they are not willing to tell you it is because of they do not want to be seen as manipulative. They do not want to be seen as weak. Or that is a layer of context there. But in the context of school, other stakeholders might see self-harm as a behavior of attention seeking. And that could be a challenge when we are working around with self-harm. And so, after we understand what is self-harm, right, and there are studies indicates 1 in 15 young people, and rare in children under 12, but risk increase during adolescence. Now, self-harm is more common in female and often have repeat attempts. In my experience working in the school for the past years, it has become more common than it used to because of social media, as well as there are kids or teens that will play games. And one of those games involve self-harm. And they will initiate each other to uh, exhibit self-harm behavior. There are also games that challenge. And the ultimate goals of the games is to attempt suicide. And so that is a context of layers that we are working when we are working with children and teens, because it's a different context when we work with adults. And so the risk is different when we look at children and teenagers as well as when we are looking at adults. Now, why people self-harm? There are many reasons. It serves as a function for the people who does it, regulate strong emotions, distract from emotional pain and stop feelings of numbness. Self-inflicted violence is a way to express things that cannot be put into words, exerts a sense of control over body, right? Self-punishment, self-hate, and also have a childhood history of physical, sexual, emotional abuse. Right, self-soothing behavior for people who does not have other means to calm intense emotions. As we talk about some of the early childhood experiences, we do understand for individuals who experience abuse, neglect, or any other form of abuse during their early period of their life, chances are they might not know how to regulate themselves if there are no any other adult or no any other opportunities or exposures for them to learn about self-regulations, especially emotion regulations. And so chances are individual will turn to eating, and this could be one of the form that they have learned unintentionally about how to cope. And so the self-harm cycle begins. As it's relieve the built-up pressure and give temporary relief, and you look at the cycle from emotional overload, panic, self-harm, temporary relief, shame, grief, and emotional suffering. Now, there are chances where I have seen clients who will tear their hair, they will scratch their skins until it bleeds, and that to work around clients who struggle and using self-harm as a way to cope, that is the tricky part. I'm not going to be here and share that is a textbook answer to all, because I believe in context as well as factors that where we are looking at. When we do consider children's cases, it's slightly different from adult about how we are going to approach it. So common signs and symptoms of self-harm, expressions of anger, were discouraged, coexisting OCD and eating disorders, a lack of necessary skills to express strong emotions. As you can see, limited social support and change in behavior, as well as isolations. When we do see all these symptoms at that point, where they're isolated, they change behavior, and that they are unable to express their emotions, they have other coexisting problems, right? We usually are looking not just at self-harm behavior in most contexts because of the symptoms that we are looking at. And I'm talking about children as well as teenagers. Because when it comes to adult, the context is slightly different. The adult developmental stages, they might have more control. There might be more maturity in terms of how they can execute their functions, their brain, the functions of their brain, and how they evaluate as well as the support that we can provide. And so, I'm not going to touch upon this for a long time. Self-harm attention seeking? It is not. Usually it's a sign that the person is struggling. And in school, teachers are, in certain contexts, teachers are taught to look out for signs. And students will wear jacket to cover their scars because they might be cutting themselves. Teacher actually will prompt and check in with them. And sometimes they actually are carrying out self-harm behavior. The more serious the injury, the more serious the problems. Is it important to take all injuries seriously, as the wound does not represent the extent of anguish? But then when we look at the seriousness of the injury, then we are looking at another perspective here. Is that is what the clients exhibiting into self-harm behavior, is it lethal? Could that lead to a point where it could die by accident? Right? It's not intentional suicidal, but then because of repeat actions, lead to loss of blood. Is there a possibility? And that's where we look at risk. When we work with self-harm clients who struggle with self-harm or clients who struggle with suicidal ideation or attempts, we are looking at a few perspectives. The first one is risk management and case management. And some people might not agree, is that if we are over focusing on risk, we miss out the opportunity to explore, to build protective factors, or that to explore another directions of the counseling sessions. Now, to continue, they must like the pain. It's not about liking the pain, it's a way to cope with the thoughts and feelings. They are depressing and distressing. Right, self-harm is the problems. If we stop this, then the person will be fine. Now, in most cases, self-harm is the symptoms, and that when we work around depends on the conceptualization of the clients. What is the concern? What is the issues? And usually, if you do work around it with your intervention plan, self-harm will slowly, gradually stop when the core issue is addressed. Having said that, in school, in the context of school, because it's minor, it's a debate where some scholars or some practitioners will say that according to the policy, practitioner has to address the self-harm behavior there and then. In other words, which means that the practitioner has to evaluate the self-harm behavior. And in most schools that I'm aware, private, government schools, they do have escalation SOP. In other words, if you discover student is conducting self-harm behavior, you have to escalate to the safeguarding officer in private schools. In government schools, the counselors will have to discuss with the relevant parties to make decisions accordingly. Whether the school will have to approach the parents to discuss about the behavior. But in private school, this has to be escalated immediately if self-harm behavior is detected. It's a safeguarding officer in the context of child protection. And so, because of it, in certain cases, some counselor will say, JK, I don't want to focus on the self-harm behavior itself. But in some contexts, we might not have a choice not to focus because of the risk assessment. So, supporting someone who's self-injuries, there's no right or wrong way to let someone know you care. Don't ignore or stop talking to her. Ask how they're feeling. Let them know you'll be there for them. Talk when they're ready and tell someone that you trust if you need to and refer them to talk to a counselor. Now, chances are when you approach someone who's struggling or exhibiting self-care, self-harm behavior, right? They will feel overwhelmed, scared, isolated, or probably they are worried that you will judge them. Because the context is that despite of we are more aware now about mental health, about struggles, self-harm behavior can still be viewed as attention seeking. And attention seeking has a negative connotation in general. People will say, you are doing this just to get attention. You are doing this just to, you know, I don't know why you are doing this. And when we look at self-harm behavior from a more ecological perspective, which means systemic, right? Friends might also be not supportive, right? Why are you doing this? Are you being tried to be famous? Are you trying to attract attention in a negative way? So that also has implication on social elements. Because when we talk about children and teenagers, we are looking at their school life, community life, uh, their family life, as well as peer support. Is one of the most important element when we are looking at children and teenagers. Now, that is on one spectrum. On the other spectrum is that you will have stakeholders coming to you and say, JK, you know what? Why they are doing all this is to attract attention. They are doing it. This is stakeholders. Stakeholder means there could be school management, there could be parents, right? And because their understanding is nowadays all this TikTok, whatever, this short reef and talking about glorify all this stuff, right? That's why my kids is doing it. And that is another context that we will face as a counselor. I'm honest because one of the contexts is when we work with clients who are minor, we are also working with the systems, be it the school systems, the community systems, the family systems, and their sub-family culture. And in terms of what do they think about mental health? What do they think about self-harm? So there's no one straightforward answer to go about this, but the general idea is do not ignore and be aware of our own attitude as well. What do you think about such behavior? Now, we know that it's not attention seeking, but what's your attitude towards it? And could that be that you also believe, this student is doing it on purpose to get the attention? Okay. And that when we are talking with uh, individual who self-harm. Now, I happen to have exposures and opportunity where I do support clients that when they do struggle with self-harm, most of my clients are also struggling with suicidal ideations, and some of them have attempted. And so later on, when we talk about the steps to for suicide prevention, as well as some of the framework, I will expand some of my points. So supporting someone with self-injuries, do not afraid to talk to the client if you notice or suspect any self-harming behavior. Be aware of your own feeling about self-harm, and this may be communicated in your tone of voice of non-verbals. And clients struggle with or that cope with self-harm. I have received feedback where clients sharing with me when the way teacher talk to them, their tone, their gesture, they feel judged. They feel oh, you don't like me, or you judge me for attention seeking. Of course, you are just another adult doing that. And so that's very important about how we are approaching it in the context of children and teenagers. But as we talk about adult, right, the reason why I have not touched upon adult case yet is because it's slightly different. And adult has more internal capability compared to minor and ability. Their brain is more mature. And usually, most practitioners will go around it with their own conceptualizations, which means that they will focus on the intervention itself and depends on how they conceptualize the case to work around with the self-harm behavior, but not minor. That minor is slightly different. Directly address your observation as a matter of way. This shows acceptance that your client will engage with you or not, right? Depending on whether if for adult client, some practitioner might be paradoxical to normalize that and then move away and work with the core issue. And because of normalizing it, client doesn't feel shame. And that in hope to discuss and slowly build resilience to move away from that self-harm behavior without addressing it, which means you are using that approach to do away with it. That's for adult clients. And that's why we might not touch a lot on adult clients for self-harm because it depends on your modalities and your framework. How do you work around it? And for some framework that views self-harm, if your client is using self-harm as a way to cope at the beginning stage and it keeps your client survive, and that's all it matters. As long as it's not lethal, as long as it doesn't, you evaluated the risk, it doesn't lead to a lethal or that dangerous harming others or your clients. And that is one of the approach. And then you move away and build other coping skills without addressing it. And so when the other coping skills your clients practice, they start to gain more confidence, they will slowly, gradually shift to the other coping skills. Just this is just an example, right? When we talk about do support clients who is adult. Now, do not if they do not engage or are silent, is a mere indication of their fear of consequences. And this is particularly true in minor. They do not know what will happen to them. And the role of being a counselor. And especially if we are also adult, if most minors when they do struggle, right, to the extent of this, right, and because of the systems they are in, remember we talk about family system, we talk about community system, we talk about school systems, right, we talk about peers, right. Most of the time they can't run away from this, and that might have implication due to an adult. Does that make sense? You get what I'm trying to say? So we are an adult seeing them in the session itself, right? And they might not feel comfortable telling the adult because some of the issue could be due to an adult. You get it? Yeah. And so because of that, trust is another thing. Do they trust you? And do they think that you are just another adult coming in here to tell me off? Okay? And there might be fear of the consequences. So, supporting someone with self-injury, do not drown in keeping anything secret. Instead, explain that you will have to share your concern with appropriate people. Now, with adult client, not so much. If you evaluated the risk is low or that you evaluated the risk is something manageable, you work with your client and that you continue to focus on your intervention plan. You can choose not to breach confidentiality because confidentiality is a big part, right? And that you might end up in an ethical dilemma. But of course, the decisions of whether or not you want to breach your confidentiality based on an adult who is struggling with self-harm, you have to, I do believe that it's important for us to have a comprehensive evaluation and understanding of the situation before you make any decisions. That might also include consult with necessary supervisors or experts. But for kids and teenagers, we are unable to keep it as a secret. It has many implications. In most schools, we are not allowed to keep it as a secret, right? And there are mandatory SOP reporting for most schools now. And government schools are also drafting something similar when it comes to self-harm behavior and suicide behavior. If they want to know what happened next, then we assure them that they are not in trouble and there will be offer support and their wishes will be taken into consideration and discuss the support available to them and encourage them to engage. Now, it helps when we are not scared of talking about it. We can express that wanted to be understand for us to understand them. Somebody accept that self-injury is a way of coping for the time being. I was told to be safe rather than told not to do it. Right? We are focusing on the sense of safety as well as plan of safety, making sure time is safe. People truly believe I didn't want to keep hurting myself, even though it didn't come across that way. That belief can be a huge relief for minor, especially when they are in a context where no adult believes them. Can you imagine the bond and the rapport that the impact you would have if you are the only adult in the room, believe that actually they do struggle, they are not doing it for attention seeking, and that actually they didn't mean to do it, but they don't know how to cope. I was offered support after telling somebody about my self-harm rather than being told I was seeking attention and being manipulated. It's not helpful when you say stupid, when you get annoyed, when you hear people laughing at them, when people's teachers say that they were disappointed, right? And people make a big deal when they didn't need to. Now, knowing this is not helpful. It's for us to be aware, right? Then the question is, usually as a counselor, we are aware. Then what's next? Is to be aware that that is the systems that we work with, the surrounding of your individual. Probably they might experience some of this taboo and stigma that will make it harder for them to tell and share that they are conducting or carrying out self-harm behavior. And when it comes to self-harm and suicide, taboo and stigma is one of the block for us for suicide prevention. Because if they don't tell, then we have to look out for signs and prompt them. Then only we gather information. There was one case where this female students always complained. She was in pain. She will visit the toilet quite often. And if the teacher assumes that she's just being difficult, right? Being manipulative. How come these students did not follow the rules, always want to skip class? But because the teacher, she was aware, this is change behavior. This is behavior that could signal she is struggling. So she escalated to counseling department. We had the case. She is cutting herself. She is skipping meals. She intentionally skip meal, do not want to eat anything. Those are the signs. And later on, we found out neglect at home and many other issues as well. And so, for kids and teenagers, they might not come to you and say, "Hi, I think I am struggling." Chances are they might or they might not. But how do we know they are not performing, they are struggling through the behaviors? And in school, or even as a practitioner, private practitioner, we do work with minor. We have to collect, in most practitioners, they collect information, multi-source informations from school, from teachers, from parents, to have a holistic picture of the struggles or the presenting issues. There might be a limitation of how much we can gather in the counseling sessions, depending on your modality, regardless, because some of the things students might or kids might not be able to tell you, right? And we might take longer time to gather more information. And so, working with the systems, especially for mine, in other words, we are looking at systemic approach when it comes to data gathering. And now, how to help, right? Acknowledge there's a problem, right? and then accept this is not about them being a bad person. Facilitate the finding of someone that can help them. That's very important. If you do notice anyone who is struggling. And if there is a time they wish to engage, help them identify what triggers the self-harming behavior. But I would suggest to do this carefully if you are non-trained mental health professional, right? And recognize that self-injury is an attempt to self-soothe, and then encourage them to find and develop better ways. I will also encourage, if you are doing this as a non-trained mental health professional, has to be done it carefully. If not, it will come across as judging. Yeah, work together to find out what functions the self-injury is serving. Then encourage them to replace acts of self-harm with more appropriate and healthy ways of expressing. Again, if you want to be there to listen, to support an individual who struggle with self-harm, I will also think you can explore it, but be very mindful if you can come across as judging. Because the last thing maybe the individual need is that you are telling the person that I think this is wrong. Then you will start thinking, is it helpful? The client is really struggling to this extent, and yeah, coming over to tell a client, I think what you are doing is wrong. Then client will feel sense of shame because it could be already associated with it due to the stigma and taboo. Okay, right. Alternative coping strategies. Now, when it comes to teenagers and kids, right, it depends on your modality. Some people will use play-based technique, play therapy, art therapy to work around, and some people will introduce a called education component. What does it mean? To teach clients how to cope. That is for kids, right? And they might introduce different coping skills, coping strategies. Squeeze eyes, do something will give you sharp sensation, biting a lemon, exercise, and snap a rubber band against your wrist. Okay, take a bath, put bubble in it, read a book, give yourself a present, and watch a funny movie. Even with adult client, we could brainstorm some of the strategies together. But of course, if you were to do that, then your modalities, your approach is to focus on the self-harm behavior. You are doing risk management and management of that self-harm behavior. It depends on the modality. Some practitioners will have different school of thought. They will say, no, JK, we move around from the self-harm behavior as long as it's not high risk. I conceptualize it, I work with the core issue, and I help clients to build new strategies without talking about the need to stop the self-harm behavior. Could that be then you brainstorm with your clients with these coping strategies? It is possible, but it depends on where your client is. If your client is not ready to talk about it, you imposing it, that will come across as judging. You are pushing and imposing, right? And how would client feel about that if you were to? Because you feel like, okay, I have to manage this self-harm behavior, right? And where is client? But where do clients want to go? Okay, those are the things to be mindful of. Now, draw or write on yourself with red pens or markers, paint yourself with red paints, squeeze eyes, exercise. These are also some alternative coping strategies that you could explore with clients. Now, as much as I'm sharing it here, I still believe in collaborative approach. In other words, collaborate with clients to explore strategies. That is very important. But before you collaborate with your clients to explore, the key things I feel like we have to also be aware is what is the rapport? How's the rapport? Where is your client? What is the issue? And what is the core concerns there? And when you decided you want to zoom in self-harm behavior, what is the justification? What is the framework you are looking at? What is your modality? Why is that you are looking at self-harm at this point? I feel it's important to answer ourselves so that we know why we are zooming in. There's no right or wrong here, especially when it comes to adult. When we talk about adult who are not high risk, in other words, we are not looking at I am cutting my risk to a deeper level, and you know that it's increasing the likelihood of die by accidents. So you have an understanding of that self-harm behavior. Later on, we will talk about it. And so when you are more aware of that, then you might be able to meet your clients at where your client is. Let's say your clients don't want to talk about self-harm behavior. She wants to talk about how she was abandoned by her parents. And if you, let's say you decided, no, I don't want to talk about that. Let's talk about self-harm behavior. Then you have to be aware. Why do you want to talk about self-harm behavior at that point? Okay? And that, what is the risk assessment there? What is your understanding of that whole case? Conceptualization, core concern, the presenting issues, and the mental health status. One thing that you will be doing consistently, even either is self-harm behavior or that suicide, is that informal or dynamic assessment. So before later on, I will touch upon that. So to ensure confidentiality boundaries are discussed and agreed with the clients, their family, and professionals. So in other words, when you go through your informed consent, you have to specify and let clients be aware the limitation of confidentiality. If not, it will harm the behavior, it will harm the rapport. And it has implications. I have clients come up to tell me that they do not trust counseling anymore because confidentiality and the informed consent was not executed done properly. Yeah, they don't just lose trust on you, and then even don't trust counseling at all. That reduces their possibility of seeking help and getting help. Okay, if the client does not want their parents to inform in regard self-harming, then do everything possible to negotiate that. Yes, I feel one of the most important skills as I continue to learn and continue to practice is to negotiate with clients a lot. Teenager, children, or adult. Now, children and teenagers depending on practices. I know some school, they for children, they have to get informed consent from parents. For children means primary students. For teenagers, they have a blanket informed consent statement sent out by the school. For some school. For some of the school, they do not practice that. Every single teenagers who walk into the door, they have to get informed consent signed by the parents first. But that practice, you can see statistics, right? Because I'm supporting a few schools. You can see that statistics wise, right? Teenager walk in, the statistics is lower. You get what I'm trying to say? Imagine you are teenagers, right? You want to get help, but you know that when moment you walk into the door, there's a possibility what you say your parents might know. Or that, if you are working with the culture where the family culture, yeah, I'm talking about not just the school culture, the family culture is where that they believe, I pay you. You go to counseling, right? Tell me, what do you talk to your counselor? That they have that belief and that practice. Can you see that it's harder for them to get help? Yeah, so you can see statistics wise. And some schools that practice blanket statement, right? Then they don't have to worry that, that whatever they say their parents will know. And so what I wanted to say is one more thing, is that when it comes to confidentiality in school in general, self-harm, suicide, bullying, counselors most of the time has to breach confidentiality. It is non-negotiable because it's safeguarding and child protection. So for minor, that is the context we are looking at for school. Yeah, even for hospital, if they do detect that there are self-harm behavior and suicide, they have to address it. That they cannot be like, okay, secret for minor. Yeah. So this is very important, and because you have many implications there. The purpose of this is that so that relevant parties are being the how do I say, the process is being initiated to involve relevant party for prevention work. You get what I'm trying to say? Prevention. Why do we have to initiate the process? Imagine, yeah, a student self-harm for 2 months. Okay, no escalation. Keep it as a secret. Student continue to self-harm for 6 months. Can you see that maybe at the 6-month point, we might be looking at a more severe case that it progress. And so from the school stakeholders and all the other stakeholders perspective, right? This is prevention. We have to do something to help the kids. We cannot be like, okay, this is secret. And stakeholders might have to be involved, for especially parents, because parents is their part of their environment. right? But it's a gray area. In other words, what do I mean? How much do you share? How much do you work? Because do you tell teacher? Do you tell parents? How much do you tell parents? Do you just tell parents the self-harm behavior and you stop at there? That's all going to be, as we grow, we will learn more to navigate that. I'm not going to lie to you and say, oh, there's a textbook answer to everything. But of course, the bottom line is if suicide and self-harm is there, chances are very high you have to breach confidentiality. Unless, let's say, the context is when you breach confidentiality, mom will kill her or him. Let's imagine. There are contexts like that where parents are the source of that, and parents will, after you evaluate, you believe parents will have no doubt to do that or to harm the kids if that were to escalate. So then you have to sit down with your team to come up with a creative solution to that if you have a team, or that you have to discuss with your supervisor if you are very new to navigate that, to look up for maybe for the auntie or that other next of kins or the guardian. Because but then when you do that, you are also managing the guardians because the guardianship belongs to the mom, and you are working around with law because you get what I'm trying to say? Guardianship belongs to mom. It is a law. It's not just simply because, oh, she's called mom, right? And so you are working with many implications there. So that's why you have to consult if you were to have similar cases like this. There's no black, like, so clear cut, right? Because the question is, if you escalate to mom, you know mom will harm her. Are you creating more harm? There's a question mark there, right? And school might say, JK, no. As a school perspective, they are managing the risk, right? School think about their reputation, right? School might think about the kids, but school perspective is different, right? As a counselor, we are advocating for the student. So you can see different perspective coming in place. So you are managing different stakeholder perspective. And that is one of the reality for a lot of school counselors. As you compare and when you look at adult cases, the complication in terms of the stakeholder perspective is less so, but more so about the clinical management of the client for adult. I'm not saying for minor we are not also looking at the clinical implication and clinical aspect of it. We do, but there is a more layer to that when you are managing all the stakeholders. Yeah. Okay. And so it comes to negotiation skills, and then crisis intervention when you are supporting minor. You might still do psychological first aid or crisis intervention with adult who constantly have crisis when come into your office or your session with self-harm and suicide. You might still be doing that instead of going down the path of deep processing, which is the stage 2 of therapy for trauma, if you are looking at trauma-informed and trauma therapy. So for primary and secondary non-suicidal self-injury, right? You look at all these, purpose of intentionally hurting. Now, and you try to understand for which. Now, usually is you can do this by us prompting and then you take it yourself instead of giving it to your clients to take it. And for this particular question, it's not recommended to do it with children. Okay, and then you try to understand the hurting yourself intention to which extent. Some clients will tell you, I will be punching the wall until I bleed. Okay, and that's how they go. So then you try to understand their functions. I hurt myself to feel something, to because my friend hurts themselves as a self-punishment or to atone for sin. So you have all these questionnaires that we might be looking at is really helping you to capture some of the thoughts and the functions as well as the symptoms. For counselors, right, when we are using it, it's just to gather useful information, not to label or do any diagnosis. There's a disclaimer here that have to be very careful and be mindful about, right? Because we want to gather useful information that will help us to work with our intervention planning. Do we have to refer? And do we have to refer to a clinical psychologist or a psychiatrist? Are we looking at symptom management? Some practitioner will tell me that, okay, symptom management and case risk management are very important. But if we zoom in too much on these two elements, we miss out opportunities to build resilience and protective factors about what is going right. Do you get what I'm trying to say? Because symptom management and risk management is about what could go wrong. Right? You get it? It's about what are the potential issues and when you are evaluating risk at that point. So there's no right or wrong answer here. Depends on the school of thought, depends on your article decision-making process, it depends on your modalities, as well as your framework and approach. And I feel the most important element is, are you aware of modalities? What are the framework? So you know what you are doing, why you are doing, how you are doing. Okay, right, wound locations. For some setting, not adult, right? Adult, they explore with you, and then as I shared before, you just work around with it, and depends on the modality, EFT, IFS, or even or CBT, right? And you work around, and if it's not suicidal, probably you might not have to do safety plan, and you build coping skills. But for minor, in certain contexts, you have to send them to see a doctor or a nurse for them to record down the wound's location. Now, I'm gonna ask one question. Do you think that, let's say your client is self-harming, right? Do you think it's appropriate for us to ask clients to show where is the injury? The answer is no, in minor context. Okay, let me explain why. Okay, let's say your client is opposite gender or same gender, right? The injury is in some private setting. As a counselor, one-on-one, it might not be very appropriate. Plus, we are not medically trained. We are unable to evaluate the wound, the nature of the wound. So the best course of action, if someone told you they are injured, they harm themselves, you can gather by asking questions. But if you want to jot down as an evidence, you have to send them to appropriate setting. That includes hospital or even nurse settings. It might not be appropriate for us to evaluate the wounds because it's also out of our competencies. Right? So that is very important because if you do ask your clients to show you and this in places that's private, okay, you can say that yes, thank you for wanting to show me. I appreciate that you trust me. I might not be the best person to see, and then you ask you, and then you send the kids to the nurse. In some schools, they have nurse settings or they have personnel in charge of it, and with the witness of it, that you pass the case, and that then that the professional will evaluate, not counselor. Yeah. Okay. For school setting. For adult, chances are they will tell you, let me show you this. That they will not. Yeah. Chance. Okay. And that's for kids. Now, again, one of the things that I find very important for us is to be familiar in the future. Let's say you are working in a hospital, you are working in a counseling setting, you are working in a school, you are working in university, have to be familiar with the SOP and the policies set by the school and your work setting. What are their SOP to escalate suicide or self-harm related cases? And is there an SOP for minor? For certain workplace, they do have specific policies guiding you to escalate self-harm behavior. That's where the question is this. One of the most common questions when it comes to this, JK, if every day have to follow SOP, right? Client, will we implicate the work we do with our clients? Because it feels like every time when it comes to self-harm and suicide, there's little room or autonomy for counselor to make professional judgment in terms of not escalating, where we believe not escalating benefits the counseling sessions. This is one of the common struggle we all have, or I used to have. And I don't have a clear answer to that. It's case by case basis. But if the school policies dictates that you have to do mandatory reporting, if you were to consult with the community, which means that we want to reach a standardized answer, right? You go around and ask the practitioner, they will tell you that if school policy dictates yes, the answer is you have to follow the school policy. But there is still a gray area, just like what I told you. If your mom, okay, no, you try to test water, and you go creative, right? Kids tell you, if you tell my mom will kill me, right? So you test water, you call mom, check in, and you have the impression mom might do what your client is telling you. Then you have to come back, okay, what's next? What are the decisions that you can make? And so working with stakeholders is one of the challenge. And it's important for us to also understand the motivation. So I feel that this question is quite helpful. So you can try that. This is the tool. It's called non-societal self-injury assessment tool. Uh, right, you have to read the disclaimer there because it put the disclaimer there, right? So you can see it's not suitable to use a behavior-based and SSI screening with secondary student, yeah? So be very mindful if you were to use it. You have to read it before you do. And I would suggest you to read some of the journal regarding this before you do, so you have a comprehensive understanding of the tool. To inform, for counselor, it's just to inform, so we capture important information when we are working with it. Okay, how this one is another one. I think I always intentionally hurt myself in private. This is a practice pattern that you try to gather also, and this one is where you can work with school, right? For younger kids, but it depends on some students might not be able to understand the language. I only use it if I already gathered information that student actually is exhibiting self-harm behavior. I just want to capture more information. Okay, now capture more information is very important, I feel, as a practitioner in school as well as private practitioner, because information gathering will have to inform your clinical decisions in terms of risk assessment, case management, and the direction of your sessions. So that's my approach. People who talk about suicide don't end their own life. Many people who took their own life have giving definite warnings to family and friends their intention. Okay, always take any comment about suicide seriously. Asking a depressed people about suicide will push him or her to end his own life. No, that's not true. Huh? You're asking them is for you to detect, is for prevention. Okay, you can't plant that idea if it's not there. Okay, uh, right. Why that is very important because but I want to give in a bit more context here. For the first one, right? Uh, for teenagers, for some teenagers, it might not have any signs. Yeah, it might not, or that surrounding adults did not detect it. And so it goes back to detection. It goes back to systems. It goes back to prevention for school. For adult can verbalize it or express it, and you will have some ideas. Let's say you have a client come in, mental health status evaluation of cannot sleep, of cannot function as work or study, of emotionally overwhelmed all the time, of then you know all the signs, maybe it's preparing you to prompt further. Are you suicidal? Because you have done evaluation of mental health, you have done an understanding of your client's struggle, and so you can ask and gather information and prompt it further. But for children, they might not be able to walk up to you and say, I am suicidal. They might say things that I wish I won't, I don't want to get up to now. I wish I can be at the corner of a room where no one sees me. Those are the language that I use. It might also reflect from drawing, art, and play. Okay? And I cannot stress how important it is to ask the questions if you think that is a reasonable justification for you to prompt further, especially when we will talk about it in a bit. So when we look at the Thomas John's interpersonal theory, right? The isolation, the burdensomeness, and the compatibility for suicide. These three things, and then we look at the factors, right? As they are isolated and they always feel burdened, they feel ashamed, they don't want to burden anyone, they are less likely to seek help, it increases the possibility. Now, this is just a framework, be it that you try to understand. The acting out, the sleep and the eating and self-harm, and then the interpersonal problems, right? Relationship and burdensomeness, and then internalizing problems, hopelessness, depressive symptoms, anxiety, irritability, self-blame, worthlessness, and loneliness. And as you can see, all these are, why do we have to understand all these concepts and all these factors? Because sometimes when your clients walk into your room, they won't walk in with all these problems obvious to you. And you have to, not you have to. I feel it's important for us to know what to talk, what to ask, where to go when you collect enough information and you go down the path of suicide assessment. And these are all the things that for us to be aware of. And you can see from histo or predisposing, right? Family issues, genetic, early life adversities, right? And nothing is changing. The environment is not changing. So imagine a student abused physically, sexually, every day cannot sleep, for body sensation and physiological sensation all haywire because fight or flight mode all the time. Cannot fight parents, right? Cannot run away, right? So freeze. Then we look at secondary worries and sleep issues. Can you imagine if that persists for 20 years? So you look at the mentally, right? So if you are fight flight, you cannot be able to regulate. You cannot focus. Chances are you cannot regulate. You cannot focus. You cannot calm yourself down. Harder for you to make friends because you maybe have poor social skills, and that lead to maybe you cannot study. Maybe there's a possibility, and high anxiety, high impulsive aggression, and then you cope. How do you cope? Maybe you are not taught about self-regulation and emotion regulation, lack of opportunity or exposure to learn, right? Then you cope whatever way that you know, either through eating or other repetitive behavior, maybe, or it also could be through any other form of addictions. And then you look at long term, right? That develop something more clinical now, which from passive for hopelessness, burdensomness, behavior issues, and then we are looking at suicide ideation from there to suicide behavior. Now, then I don't want to go into this. Maybe you can have a look yourself because I want to focus on this part. From passive, right, and you are moving towards active suicide, and you can see the connectedness, right, belongingness, are two of the element as well, right? If you feel isolated, you don't feel belong, and where from I just wish that I will disappear to I want to end my life. Okay, now this is what they look at. You can see that for the passive one, thoughts that life is not worth living or would be better if dead, right? And two, then has considered a method of harming, okay, ending life. And then two, all the way executing. It's very specific plan. Now, I want to spend a bit more time on this. That's why I scroll through that part. Because for that, just for you to have an understanding, when it comes to understanding suicidal behavior, although scholars are still working hard to try to decipher it and understand the implication as well as the mechanism in more detail. So let's focus on risk factor. Because risk factor is where we do assessment. Okay. Everyone still okay? Right. So risk factor, psychiatrist disorders, past suicide attempts, symptoms factors, hopelessness, chronic illness, social demographic risk factors, male living alone, environmental risk factors, accessible means that easy access to little means, and contagious influence. Now, I want to share this. So remember that, okay, for these studies, right, they list out all the factors. I know that it's very hard for you to read it, so I just want to share a bit. Social isolation, unemployment, low social economic status. And so I have been trying to understand because it used to be not to my own awareness. Oh, poverty can be a form of stressors we that have to be evaluated carefully when it comes to risk factors. And in most recent years, right, especially when we look at the category of suicide, right, when we look at this, right, Now, of course, this is 2015, right? Most recent studies, there are some statistics emphasizing on age of 40 to 50, during pandemic and after pandemic, attempt suicide due to financial crisis. So poverty and financial and social economic graphics, right, can also be part of the very important element for us to look at. And these are all the studies that have reviewed in terms of when it comes to risk assessment or risk factors for suicide. As you can see, unemployment, low social economic status, low education, single, low income, living alone, non-religious, not having children, so on and so forth. But I want to highlight a few things here. Past suicide attempts, there are many studies when they do attempts two or three times in the past, with there's a stronger likelihood they will attempt again in the near future. And so, why is this important? Why do we have to talk about risk factor? Because when you are conducting session, when you are doing risk assessment, it's very important for you to be aware. Let's say you do a risk assessment, your client cannot sleep, your client emotionally overwhelmed. Then you decided to do family of origin. There's a question mark there, right? That the decisions of pursuing and continue to explore family of origin at that point. So in school context, right? If your client cannot sleep, feeling overwhelmed, no friends, usually the common context in some of the policy, counseling policy we are talking about, is you have to prompt and go into risk assessment. In other words, mental health evaluation has to be done. And if you are not doing mental health evaluation, if you are going into family of origin, some will even argue that could be a form of malpractice because you are missing something very important, which is the risk. This is for school setting. But even let's say adult come to you, you clearly see the adult is off, mental health wise, cannot sleep, isolated, feeling low for a long period of time, and you didn't prompt further. So it's very important to have that comprehensive view. And let's say I tell you, I have attempted 2 or 3 times in the past. And why is this information very important? Because for practice, right, then your risk is elevated. Your evaluation of your client. Let's say I attempt 2 or 3 times in the past, but right now I'm functional. I have friends. The context is I don't have issue. I can sleep. Okay, right? No, she's manageable. Then you go on and test. Oh, do you still have suicidal thought now? You go on and do that exploration that is needed. But compared to a different context where your clients cannot sleep, cannot function, struggling, and your clinical decision is let's do family of origin. But let's say you are doing a family of origin in hope to evaluate the factors, the protective factor, that's a different story, right? But still, risk assessment has to be done in most settings. And failing to do so, your client will walk out of the room. You have some signs the client is not doing well, but you miss the opportunity to intervene, have early intervention or prevention for suicide. So it's very important that we look at risk factors. Let's say your client tell you, study, cases, this student study. Every time he try, he fail. Parents been telling him it's because he's not hardworking. Teacher is telling him that he is stupid. He cannot sleep. He's anxious. And without the knowledge of risk assessment or that trauma informed, sometimes you might go in to just do some therapy, right? But if clients cannot change and start to feel hopeless, then risk assessment is needed. Because is she suicidal? That question is very important. Now, of course, we can say in adult client, right, we always will ask that questions in the intake form. Are you suicidal? How frequency, the intent. We do for some setting, right? We do collect that information. But let's say your client didn't take right? And in the session, everything is suddenly seems to be kind of struggling a lot, and the mental health status is off. Then the risk factors will help you to capture most very important information when you are doing an evaluation. Let's say male living alone and uh and also feeling having let's say chronic illness. This is one of the things that I was learning. I used to have one case. This this lady, she came in, she feel low, and I try to understand, right? I try to conceptualize what is influencing, what are the factors presenting everything. I cannot get around it. And then I realized one thing. When she was young, she will lost control of her body and collapse. And that sense of losing control, you see, towards your body, the relationship that she has with her body, and adding to that, she's been managing her chronic illness. Because some intake form you might not have chronic illness intake, right? That is part of it. And it turned out she was suicidal because of that. She hated herself so much. And she hated her body so much. So you get what I'm trying to say? And so that become, oh, right. And so understanding when it comes to conceptualizing it, when you try to collect information, chronic illness is also one of the elements, as well as poverty. Right. And so that's why suicide attempts, I think, is very important. Mental disorders, any form of mental disorders, adverse life event, relationship conflict, legal problems, family related conflict, financial issue, early separation from parents, all those are risk factors. And grief, of course. Yeah. And sudden grief can also be a risk factor. Remember, after the pandemic, I was supporting a few elders. What happened? Their store, this uncle, their store, has been working for 30 years. And everything closed down, right? He lost his identity suddenly. And coming in here, very low, male, elders. So, trying to understand his experience, right? And I would have missed that questions if I'm not I try to be very careful. Okay, male, elders, suddenly 30 years of shops closed down, right? And how would he feel? Stuck, sudden change, maybe hopeless also. So I thought, okay, then elders, men, right? That generation might not tell you feelings. You get what I'm trying to say? Culturally, to work with that culture and understand that demographic, right? And turn up, he was suicidal. He might not tell you upfront. In the questionnaire, even he left it blank. And so it's important for us to understand. Now, any present of mental disorder is associated more than tenfold increase in the odds of suicide, as well as a history of self-harm. So it's very important for when you are doing the understanding, when you are doing the intake, or then as you continue to progress. And 71 suicide descendants report to have mental disorder all the time, and 29 having previously attempted suicide. And that, of course, mental disorder is a strong risk factors. Legal problems and interpersonal conflict are also associated with suicide risk. And that, right, okay, we'll go back to that. Now we are talking about Malaysia. Okay, you can see that it's 2014 to 2019, there's a significant increase. And we technically have 5 dates per day. Okay, and then this is the statistics for both. The blue one is male, the red one is female. As you can see here, when and that when uh, when male do attempt, they usually will attempt with more determination and harshness of the method that they will succeed, more likely to succeed as compared to female. And then you look at here, then this is the part that I feel like, when I was looking at these statistics, I feel sad. And as you can see that there's a increase starting from 10 to 14, and it declined after 20 to 24. And then, in other words, right, but for this part, I'll show you this. This is adolescents. The statistics for adolescents. There's an increase for that. And they're talking about youth, Malaysian youth, as for these two slides. The point I wanted to highlight is that there is an increase in high school attempts and complete in the past few years. In terms of statistics and in terms of support as well. And of course, as adult, right, we also want to talk about it adult. Later, we'll talk about it for risk assessment. For adult, it's about taking certain risks, modalities, based on your modalities and framework, and negotiate with your clients, as well as using safety plan. And you work around it with a clinical supervisor if there's one, and to particularly supporting and using your own intervention plan as well as according to your modality, right? When a client committed suicide for adult, we grieve lah, right? I grieve as a counselor and I process my grief, but not when in school. The implication is very heavy. So, okay, to paint a picture why is increasing, as you can see now, for 2015, the prevalence of mental health problems, you can see is highest between 16 to 90. And this statistic is even not the most recent one. I remember after pandemic, because I am now supporting a few schools as a supervisor. Right? So what happened? We had the student lost their identity. They used to be athletic. After the pandemic, they gained weight. They lost the opportunity, so they grieve. They don't want to go to school. They have spiked up the suicidality. Many parents were struggling. Even now, parents are still struggling because to catch up the AI, to catch up all the gadgets, catch up all the policies, parenting skills, is a very different challenge. For adult, we are mature, so to speak. We have more tools and ability and capability as compared to minor. But they are adapting to the world, and that social dynamic is very different from what it used to be. They're comparing who is famous. Yeah, they're talking about skibidi toilet that I try to understand. Apparently no meaning. Yeah, apparently no meaning. So they just use it as skibidi toilet and they like the sound of it. So I have to catch up with their lingo and what games they play to understand the dynamic, right? And you can see that when a student committed suicide in school, first, all of their friends are affected, teachers are affected, school are affected. There are three layers. So when it happened in school, what we need to do is to do post-crisis intervention. So we have to set up crisis centers to counsel students who are affected. That's the first thing. Then the school have to do the PR crisis thing to let parents know about it, because you cannot keep it secretive. And counselors will usually be very busy. Why? The school that I used to work for, a few other schools, right? At our peak, we have 50 students to 70 students per week. And on that 50 and 70 students, on top of that, we have another list called monitoring list, which those who are on that list is high risk. And we have around 45 to 50 students who are high risk. And can you imagine, one student committed suicide, it elevates all the high risk students. So we will have crisis after crisis after the situation. So you can see it's like a community. It's just that when it happened with an adult clients, right, we can't reach out to their friends to process it. And usually they will initiate, and that we will grieve it and process it in different ways with adult clients. And so the implication is, with that in mind, is we do see an increase in teenagers as well as children. And at the same time, of course, adult clients wise, we can see the statistics are here in terms of the age range. Okay, so now we will go into the assessment part. First thing, plan. Intent means prior attempts and substance use when you are evaluating? Does your client has a plan? What is your intention? Sometimes clients think about it but don't intend to do it. Okay? Is it accessible to the means? Has there been any prior attempts and substance use? Now, one of the things that I have, because I'm trying to read and understand a bit more with substance use as well, and it make it easier for some of the individual to attend. That will just take, right? And this is one of the factor. And because for teens, right, sometimes I try to understand a bit more, right? Some mechanisms that scholars are trying to understand. Some teens, when they are attempting it, right, is at that moment of impulsivity. That is one of the factors also when we look at teens, when we look at children. And that is very important for us to know when we are evaluating risk. That's why school always tell me, JK, we have to be very careful because of that. And truth be told, right, I have cases where student commit suicide, and we have been managing the risk to medium to low. And but stresses trigger the capacity of the tolerance or the capacity for them to handle becomes so narrow. At that moment, the impulsivity also there, right? Just attempt and completed. You get what I'm trying to say, the complication. That's why there's no like, okay, only one answer clear. But for teens, impulsivity, we have to take into consideration. And there's also something called revenge for teenager. Of course, adult it also could happen, but more in the States. So that revenge, use gun to kill. As a revenge. And write down the letter is to revenge you. So it can also happen. Stuck and hopeless to the point, right? So when we look at all this, right, it's very important for us to be aware. And substance use, right? I have been supporting many clients who are trying to attend with substance use. It's one of the accessible. Buy Panadol alone. You get what I'm trying to say? And another thing for us to know and for us to ask is the client practicing. So when they start Google, it's one thing. Okay. When they have plan, it's one thing. Some clients will start practicing. And they will open the door, see the distance, evaluate. You get what I'm trying to say, right? They are preparing, right? That also will change the risk that we are looking. And then client tell you, Shin, no lah, I think only, but the more you ask, preparing, you get what I'm saying? Sometimes client will joke around with you. Because they feel, it will change, right? You get what I'm trying to say? Sure. No lah, Shin, I'm just exploring, but I won't do it long. Then the risk is something different. Get what I'm trying to say? And so then we look at low susceptibility, moderate, and then high, right? Based on this. And then you make a evaluation of it. Little, quick plan, substance use not present, no previous suicide attempts, moderate one, highly suicidal. Now, this is suicide ideation evaluation. If you want to explore with your clients too, you can do that. I have no will to continue my life. I have come up with certain ways to end my life. Right? This is YASSM. And then back hopelessness. I like to use these skills a lot to inform my practice because if client is already in here, right, stating to me, my future seems dark to me, and I don't get the break. There's no reason for me to believe I will in the future, and all that capture narrative help me to understand to which extent client is of feeling hopelessness, and then I have to work with stakeholders for primary or for adult, which confidentiality with family members. To even clients who work with parents who send hospitalize them. Some of the cases, parents will send them to the hospital for the hospital to take care of them. But of course, government hospital. Some hospital, you can call for ambulance for government hospital. They will come and pick you up and hospitalize you. For suicidal clients, that's one of the things I have learned throughout the years. There are some clients who will tell you that, JK, I think I'm not okay and I want to be hospitalized for someone to take care of me. Then they will hospitalize themselves. Then go to the so for more urgent one, can call it. So now counseling clients with suicidal ideation. And okay, they do not wish to die but cannot imagine continue to live in their current state of psychological pain. They want to end their pain. That's one of the things that we talk about. I'm not going to go into the ethical rhymes of talking about suicide here, because there is a whole topic about ethical rhymes of respecting clients' decisions, or no, do not do harm, and then there's also another debate about allowing clients with terminal illness to end their life. We are not going to go there today because that's not the main thing here. So, right, before I talk about this, I will extensively talk about this part because I feel this is very important. So the first thing we assess the lethality, right? We establish rapport, we listen to the story, manage the feelings, explore alternative, use behavior strategies, and follow up. There are several steps here, right? But unfortunately, you are not doing these steps in the detailed way. You get what I'm trying to say? Because when you are connecting with your client, you are establishing the rapport, you are listening to the story, you are managing the feelings, you are at the same time. It doesn't go as linear as a checklist, right? Because then you will seem very mechanic, right? Where you are doing a checklist. Because most important part where we are there, our present, we are regulating our client is also we are there in curious, kind, gentle way. What happened to you? And I'm here to listen and support you and hold that space. Because it's very easy for us to get carried away about the checklist, right? Then we seems mechanic and cold and distance, right? That is going to be the challenge there. And so, unfortunately, after I say that, I have a assessment that I like to use it a lot. I really like this. So, have you ever sleep and wake up and just wish for everything to end? You are checking for passive. Have you ever thought about ending it and killing yourself? And if you do, what is the frequency? What is the intensity? Is it just passing thought? Plan my funeral. I have great plan and specific plan. What is the intention to carry it out? I won't do it. I don't think I will do it. Not now, but maybe. And then you look at the emotion. How are you feeling at the moment? Sometimes clients will tell you overwhelmed, or they tell you, I feel nothing. They're numb to the point that I don't feel anything anymore. Do I feel hopeless or helpless to change the current situations? If yes, okay, then you also gauge, you are gauging now, you are getting information. When you think of your current emotional stage, what do you think about yourself? When you have a negative change in your emotion, is it intense or extreme? And do you act impulsively when you are in extreme emotional state? And you ask for example if they do. And behavior, have you attempted suicide in the past? When was the attempt? And you have to jot down the times and the date for school. For even for adults, right, I will recommend you to still do some history intake to gather that information. That might be relevant to you to evaluate how's at home like. Let's say she told you 1 month ago, as compared she told you 2 years ago, it make a difference, right? Because if so recent, am I looking at another attempts? You get what I'm trying to say? And so knowing that history is very important because some practitioner they ask, oh, when was like, oh, do you have any attempt? Yes, that's it. They move to the next items, and we want to capture the risk more accurately and carefully. So we might, I think it's good for us to prompt further. When was the attempt, and how was it? How did you attempt? Later down there, you will ask. So have you Googled suicide and so on and so forth? Has there been any complete suicide in the family? You are looking at genetic, you are looking at environmental factors. Are there any current medical and mental health issues? You are looking at chronic illness. You are looking at any mental health condition. Does the client's immediate family have a history of abuse? You are doing certain level of prompting, gathering information about the environmental issues. And the potential, is there a potential or has been a sudden change of social status? So I want clients, right? Initially, the risk is low, right? No. Parents went bankrupt during COVID. That changed everything. and the risk elevator. All right. Okay. And so, litany of methods you have to evaluate this one, and available means to complete plans, preparations, and practice. You can see, preparation and practice is very important for you to gauge. If let's say your client is telling you that I have a plan, and to gauge it further and to evaluate so that you have a better understanding of it. And then you start to look for protective factors. Belonging. Do you have close relationship with family? Do you have any close friends? Do you have someone that you can depend on? What do you think about yourself? And name three things that you about your aspect, the aspect of your life that you are happy with. And also look at spirituality and cultural wider support. And it's not it's common for individuals who have suicidal thoughts, right? They will tell you, they will share that no, no, no close relationship with family, no one they can depend on. The only person they have is themselves, and low self-esteem, nothing to look forward in life, no spirituality, no culture, no CCA, no activities outside of their life. Even at workplace, I hate my work and all that. It is possible to look at to that extent. And then it goes back to safety plan. It goes back to your clinical judgment. Do you want to refer for a psychiatrist? To what symptoms that is, and what is your competencies, your area of competencies where you can work with for this moment? Because the implication is not straightforward. When you are asking the question of referral, we are also asking if we refer to our clients, right? Will we create harms? Will client take it as a rejection? It's like some clients for us, um, am I too difficult to be support that you have to refer me? They feel rejected. So it's not so straightforward when you, okay, right? So you have to, the execution have to done delicately. Like for example, I refer you to see a clinical psychologist, but I want to continue to work with you. But that's just for us to capture some information so that we can support you in a more holistic manner. I want to customize that support so I can be more accurate when it comes to supporting. And all, depending the rapport you have, you want to build the rapport, especially the first session. Is it possible to happen when on the first session you are doing risk assessment? Yes, it is possible. Your clients come in with complicated symptoms. And I'm guessing for clinical psychologists, you might be able to prompt and start the assessment and some ideas here and there and deciding what kind of assessment you will be proposing to your clients. But for counselors, we are gathering information for referral. Okay, and that's very important. Now, if you have gathered all the information here, it's high risk, and you have cognition, right? Oh, I think about ending my life. Emotion is overwhelming. I have attempt before. I have no one, family members maybe abused before. I have tried a few times, and I have plans. I'm starting to prepare and practice. I don't have anyone I can belong. Spirituality and coping skills. Then you talk about coping skills. Explore coping skills. Yes. For school, I will extend whatever hours I need to do this. For adult, I will extend maybe 30 minutes to complete it. And I will complete this with safety plan. If not, I will not end the sessions. It will end with safety plan because the client is not okay. And I might, like for example, I used to work with EAP. I'm still working with EAP, right? So they have a SOS policy. So any urgent, I kick a SOS, the relevant party will reach out and reach confidential. And client is aware of the SOS. And I have to make sure that I have done all the due diligence on my end. Because the liability is that I'm aware between this session and next session, clients attack. And I have liability in that context. Because I haven't done all my due diligence. And the best practice for suicide prevention is risk assessment and safety plan have to be complete if you detected there is a risk of suicide. And even referral or the decisions for breaching confidentiality if it's needed. The whole thing has to be complete. That might include extending sessions in the justification of that. Because we have to justify why we are extending. And in that context, it's very important.
And different companies will have different policy. For some of the EAP company, they will state that. But when you are practicing privately as a freelance, your liability also different because you don't have a team. The responsibility might be there, you don't have someone to consult. You have to breach the confidentiality yourself. Call the parents and what's not. Sometimes parents might not pick up the phone. There was one time I have this case, highly suicidal, this individual. I was supporting as a freelance counselor. Sister was calling me. This client went missing, thinking about attending. So then you have, for you as, let's say you're practicing as a freelance practitioner, you have to have policy and SOP that you have to follow to guide your decision-making process. Because sometimes when things happen, right, you have to be making a lot of decisions at the same time. As you can see, right, the list is long. When you are doing this, right, you are also evaluating, you are also building rapport, you are also checking in, feeling, because you cannot do this mechanically. Because one of the questions that I always got asked, of course, when we are starting up, when we are learning, when we started to do all this assessment, you can checklist a bit because you are still practicing, right? But when you are really out there doing it already, right? When you are getting more experience, the goal is that you are not doing it in a very mechanical way. Because there are moments where they share, wow, I can see this, but yet, there's a part of you that when you share this, how you are coping, you went into empowerment because you see the opportunity to go there. You get what I'm trying to say? When you are doing this, there might be moments where you see you can capture and empower it. You don't want to miss the session. And okay lah, some practitioner will say, JK, it's okay to miss the session because it's important for me to complete this. It depends on your priorities. It depends on your priorities and your modalities and your framework. I'm not going to give you a straight black and white answer, right? But if let's say you have enough time, right? I know I have enough time, I can complete what I need to complete. I might go and empower a bit. But client's view, there is a client's view to live. I saw it there. And I want to capture that. I don't want it, remember we talked about, we don't want everything just be about the risk assessment and symptom management. We also want to see, client views to live. And that is very precious because client brought it up. And I want to capture that and empower it. There will be moments like that. There's a chance that when you go in and capture it. And so what I want to say is that it depends on priorities, it depends on the context, the time ability, and the decisions that you can make. Can you extend your session? Let's say, right, if you are in a room, it's booked for the next session. You cannot extend. What do you do? Go to another room where you have to complete the safety plan. Can you let your client go out without a safety plan? Cannot. Yeah, the answer is, if let's say your client is high risk of suicide. Yeah. So that's very important. And coping skills, to explore coping skills, to teach coping skills. I have one client that I've been supporting. So now I feel that when I'm starting out, maybe, I don't know, maybe it's a wrong impression that I got. I don't have so many suicidal clients when I'm starting out. I feel like I have more and more nowadays. So I think personally, as a mental health professional, as a counselor, as a clinical psychologist, I don't think it's something we can avoid at all. And we are bound to it, and whether or not to learn, and then, because it's just not just a technique part as well, not just all this framework and knowledge, also as an individual, our emotion part, us as a human, as tool in the session. For me, it will influence me whether or not throughout the whole process. And so what I'm trying to say is that when we are supporting that, we are also making many decisions. We are also evaluating, do we have enough time? Do I want to prompt further? Do I want to go for helplessness skills? We are making many decisions there. But these are the framework for us to go around. When we are starting out, it's okay, you are going items by items until you get a bit more familiar. You will know, okay, you can skip this, you can prompt this. This one you asked before, because just now she came in and talked about it, about family. You get what I'm trying to say? And what is the missing information here? Oh, has attempt. When did you attempt? Can I ask? Oh no. Were you alone at home? How did you attempt it? So we want to get some of the ideas as well. And so it's very important, especially for minor. If let's say minor is attempting at home, you go to let's say you escalate this, right, to a safeguarding officer. And very important question, the safeguarding officer might ask you, were there anyone at home Why is it very important? Because we are looking at the protective factor. So when we are looking at coping skill, when we are looking at spirituality, when we are looking at self-esteem, when we are looking at belongings, right? We are gauging what are the protective factors for the clients. And we are, for minor as well as adult, we are looking ecologically, which means ecological perspective. In terms of community, what are the risk factors? What are the protective factors? In terms of friends, what are the risk factors? What are the protective factors? We want to explore, and as we are moving down this plan, right, we are doing something very important. We are trying to evaluate when what are the protective factors we can help client to grow and to nurture. So when you are after you've done all this, right, you decided some of the topic you want to deepen it to understand, have a more comprehensive understanding, you can do that. Okay, and then you write it down, your evaluation, what you do, and then you follow up what you need to follow up, and supervision and consultation. I want to say this. This is my advocate, my personal advocation. I believe no matter how many years of experience we have, it's important for us to continuous to be consult and supervise. And that as we move around the complexity of each cases. So when you are starting out, I still strongly advocate that as you continue to practice, you are continuously to be supervised. And for some element or some cases, it's important for you to consult and consult with your supervisor about the decision-making process, whether or not it be adult or minor. Minor could be having more implications because of the stakeholders. So you will focus a lot on about crisis management and stakeholder management. Right. So we are building the rapport. We are establishing counter transference, manage their emotions, and normalizing the topic, as well as convey come through avoid short declarative sentence, basic counseling skills. In essence, we are using that to build establish rapport, and together to work in a more collaborative approach where we work together with your clients to explore, to discuss, and including safety plan, including other coping skills, to growth coping skills, and the decision to seek help. So you can see, right, as you are doing this assessment, as you are doing all these steps, right, not to make you feel overwhelmed, but I just want to share this, right? You are also deciding whether or not you want to breach confidential. You are deciding many things at the same time. Of course, and you started to practice, you usually will be supervised, and that's where how you learn the process. Because you will also feel panic, anxious. Let's say your clients came in, your first client, suicidal, right? That's the journey, right? And then you are doing all this risk assessment. At the same time, you are considering your ethical decision-making process. For in school or in private practice, that is very important, including who you consult, what is the consultation result, what is the feedback of the expert, what is the feedback of the lawyer, when do you consult, all this has to be documented to protect yourself against any liability. Sounds a lot of work. So it can be a bit heavy for suicidal cases when you're supporting clients who struggle with suicidal ideation or attempts. Now, the question is this: 100. I feel like it's 1,000,000,000 questions I got asked. But if your clients came and say, I want to end my life, but if you tell someone, I will end it. Dun, dun, dun. For adult, right, we negotiate, right, with safety plan, right, we evaluate, right, there's a room for negotiation. And you take certain risks and you document down your decision-making process. And based on your modality, you work around with the adult. Because the adult take the effort to come to see you and sit in your room. So means the adult wants to change. There is a will to live, right? And you focus on that and you work around with the adult clients. There is a possibility to negotiate that. But what about with minor? So what we did is we be curious about behind the thoughts. What makes it so what happened? What is influencing this thought? What makes it difficult to share? and they try to understand the family, we try to understand the, and then we understand everything already. We identify the protective factors, right? We negotiate with clients. Okay lah, cannot tell parents. Okay, what about we tell your brothers? Brothers is adult. Do you feel safer? Okay, then clients understand. We try to understand. We are not like another adult pushing, telling the straight face. No, we will tell regardless whether you like it or not. We work with the minor. We collaborate with the minor, and we work. But this is when in the context of counseling. This is if the student walks in or refer to counseling. If the school is alerted before counselor, we might not have the options, which means school will not care. They will go directly to escalate to the parents because school, they will not tell school. They will not tell teacher, my mom will kill me. They will not. They don't feel safe enough to talk. Usually they will talk to mental health professional, right? They might not tell teacher. So school decision, if it's to escalate to the parents, right? When they come to our room, then they won't talk about that. They might be secretly telling you that since they tell my parents, I will just end it. Then you have to another way to manage it, safety plan. There's a possibility you might have to let the school know. If the kids come in to tell you that, since the school decided to tell my parents, right, I will jump. Then you have to immediately crisis intervention, safety plan, and school has to be informed. It can be very exciting. Exciting is a wrong word. It can be very challenging to work in a school. In some settings, I have clients Insta story about jumping, and we all teacher rush to grab the students. Many situations. So it's very different now, the dynamic, as you can see. Also, students post on social media last word. It happened before with one of the very influencer before. That the effect, influencer effect, social media effect. And so that's why the dynamic and when it comes to the landscape, when it comes to supporting children and teenagers, the challenge is there. And because when that happened, right, counselor has to respond immediately if you are the only counselor in the school. So we listen to the story. 70% of individuals who die by suicide communicate their intent to someone else in the week before their death. Listen, understand, and validate. That's very important. And slow things down. And that create therapeutic window. I find this crisis stabilization, right? And put the balance between clients and suicidal ideation is easier to say, it's harder to do it. And I feel I will continue to learn myself as well, that this will take experience and practices. That's the only way to get it, is to really practice it. Because then you are deciding, right, the factors, which one you prompt, where do you go, and what is the framework and justification and your clinical judgment guiding that decisions. That is very important. And sometimes you know the intuitive in there. Client is telling you what client needs. Yeah. And especially that also focusing on adult client coming in, the view is there. How do you want to navigate it? And you want to empower without invalidating. Because if you look at the silver lining too soon, what happened? Clients feel like you're invalidating their struggle. I know you have been through all this struggle, but you know what? You are still you are looking at silver lining now. Is it too soon? How will client perceive that? Because of course, empowerment, there are many ways to execute it. And there are more gentle way where you sit with client and really, I can see your pain. I can see, wow, how amazing you are to walk to this stage despite all the pain. Don't know how you've been through that. It's a very genuine, curious questions you want to know, and client will answer you and tell you their strength without you doing the silver lining. And that is some of the way, right? And so, any other questions you have? Listen to the story. Because I know you suffer deeply, I'm only asking that you travel with me for minimum of 4 weeks to max of 3 months. At that point, we decide together whether we should continue our journey. And beyond the first tier crisis intervention, psychological vulnerability, mood disorder, prioritize problems into those that can be addressed early and those who must wait for long-term counseling. Increased sense of achievement, right? And again, you are deciding that which one to prioritize, which one you want to address. I remember one of the settings I have in some of the one of the schools. We have someone suicidal waiting at the door, and in the room we have someone sexually abused, and we have to choose which one to prioritize. And when we prioritize, we are doing risk assessment. Then we are doing crisis intervention, and then we decide where to go with the time limitation and the resources and the energy that we have. Okay, listen to the story, identify the message. Communication is to communicate to others. Okay, I won't focus on this. Manage the feelings. Okay, so when we look at explore alternative, right? To help them to recognize alternative to cope, right? In terms of coping, it depends on how you are working on this particular issues. I'm not going to give a textbook answer to this either, because if your alternative is that in other than suicide, right? I want to help you keep you safe. Can we talk about some ways for us to keep you safe? And then depends on how client is responding to you, the rapport you have, and then to explore. But if the execution is in such a way where client has to defend, why are you stopping me from attempting? Then I have to defend why I feel like I need to. That is where the rapport will be impacted. So there are many ways to go around it without confronting the thought that you should stop or you are not allowed. Safety plan could be one of it. How can we keep you safe is one of it. In school, one of the SOP is we will discuss how can we keep you safe. And we will also have clients to look at, if let's say they say no one care, we will explore about that in school, what are the people that do care about. And sometimes when school, family is a place where they have no protective factor, school is the protective factors. And that we help them to put that, because during one of the questions as that we talk about, right? We want them to help them to put in this 3 things and aspect about your life that you are satisfied with, or that you feel like it's important to you. We want to help them to explore that. For adult clients, I might tell you certain things, and then you continue to empower or zoom into things that are working right with them, the protective factors. So empowerment is also equally important as we are looking at the alternative, right? Clients see suicide as a solution, not a problem. But counselors as mental professional or stakeholders might see suicide as a problem. And so to work around that, helping clients to keep clients safe and the core issue that is causing that suicidal ideation. But of course, it's easier to say it because there's so many things we talk about, right? As we are taking note, as we are being aware. And one of the things for us is if we were to work on the core issue, when do we start working on it? Because you do crisis intervention, you do risk assessment, you do safety plan, you might not have little room to talk about what is the core issue. And the framework and the question is to ask is that even do client need us to focus on the core issue at that point yet? Because there's a crisis ongoing. It's like the example is like the house is on fire. And the student is in school, right? We walk over to the student, hey, you need to study harder. So that might not be the most prompting response. So it depends on, I'm not going to say, right, it's a must or it's a black or white. The point here I really hope to share is critical thinking, evaluate all the factors in the context that we discussed, align with the law, as well as the ethical making decision process, as well as ethics, when we are work supporting our client with self-harm and suicide. Right? Okay. As you are exploring alternative, engage social support. Now, creatively, if adult clients is isolated, it's very hard. It's very hard to encourage social interactions. They might tell you no. They might even eat by themselves. They will not they go to work by themselves. They are struggling, they feel shy, then you work around with them. And one of the things that depends on modality. Some therapies will model that social the support in the session itself and using therapies as a form of support and build that as the resources for clients to sustain. Some practitioner will argue that it's codependency, but I argue it's about what and when. If your clients have positive interaction with you as a therapist, as an adult relationship, and build on top of that as a foundation to encourage clients to build social interaction outside of the sessions, then we have a goal there. It's not about codependence. And so for adult clients as well, that is the context, right? If we were to talk about building, exploring. For society, for minor, we might have more tools if we are working in a school. It's something called social intervention or social engineer. We engineer an intervention for our client. For example, we arrange a pair buddy for clients. We invite clients to join, for example, mental health CCA. So we can do something that with the environment to support clients to build that social support. So that's in school. It's a very systemic way of looking at it because you want to help clients to build protective factors, but not adult. Adult is another way. Okay, and also be aware that sometimes family members is not supportive, so we also have to be mindful, right? Let's say siblings, no good relationship. Oh, friends, yes. So you see some clients, right, when friends is their only protective factor, as you continue to support them, you are building their strength, you are building their coping skills. They will come into your room every time they have friendship issues. Because it's one of the pillar, right, that break, right, and that escalate them to highest risk. And in hope what we do throughout the session, we hope to help them to build their social skills so they have a few more pillars of strength, not just friends. As we move along the way and to build resilient building, to build coping skills, to build any other positive experience for them to know, oh, actually I can do it, to empower their sense of self. But all of that take years, times, especially with minor who comes into you, let's say they are suicidal already. It takes time for them to go there. You get what I'm trying to say? It takes time for them to go there. And if they experience something adversely in their life and impacted them significantly, is there already? And no early prevention. It's still considered early prevention if you have any intervention in school at that point. But then we capture that 6 months later. Clients finally cannot sleep. Oh, okay, I try counseling, comes to see you. 6 years of that habit, of that relationship with body, or maybe relationship with the emotions, overwhelmed, do not know how to cope, break down often, and do not know how to socialize. Because if you break down often, you don't know how to socialize. And it has social implications as well. Yeah, that always break down, don't know what happened to her. So people will avoid. You get what I'm trying to say? And so we are working with all the elements when we're working with adult, minor. Of course, then adult is slightly different. It could go a bit more clinical implication. We are using us as a tool to teach clients about socializing. We can do psychoeducation. We are modeling what it means to be therapeutic, reliable relationship using our therapeutic alliance and all that, right? And you can go a bit more therapeutic, and then you have the end goal in mind, and you build along the way with the intervention as you do risk assessment, as you do safety plan, and you focus on the view. Clients have the view to want to live, and you empower them. Then you go strength-based approach, trauma-informed, and then maybe it depends on the modality. Are you using CBT? Are you using IFS? Are you using EFT? Depends on the modality. It can go a bit more clinical, but minor, you are working in systems as well. There are still possibilities for us to work with systems, even as a private practitioner, right? Work with teachers, work with parents. Sometimes parents, they do care. For private practice, right? When parents come to your door to want you to support their kids, right? They care. They want to support their kids. If not, because they have to pay the fees as well, right? So that their way is different. They might have expectation of the session, but they want to help. They want to support their kids. Okay, to restore hope, this has to be done very carefully. Do you get what I'm trying to say? Because let's say, hey, I'm feeling very hopeless. I think you need to be hopeful. How would you feel? You get what I'm trying to say? It's like you're invalidating me. But of course, sometimes as a counselor, we also worry we haven't done all the thing. We also worry like, will client really attempt? Get my answer. And then you want to really help client to see the hopefulness of it. And I find the way to go around it is if you catch client's view to live without telling client to the face, you need to be hopeful. Because clients will show you one. They still are in your session. They're still telling you. Like the one that told me, right? My mom see me as nothing. But she still never miss a session. Consistently in the session. That's the view there. And I want to capture that. And we work towards what? Creating a goal and a life that she deserves. Despite of parents or environment. She wants to graduate. She wants to go to university. That's the hope she wants. Despite of all these unfortunate events happening to her, that's part of her she wants that we capture that. Without telling her she needs to be hopeful. Those are her hopes. You get what I'm trying to say? But of course, it takes time to capture and to see. Because the execution of that also have to timing. Because if you capture the hope and the view too soon, right? Maybe client want to tell you all the struggle first. Why are you telling me my view now? Oh, okay, I know I want to leave, but I want to tell you how painful I am. You get what I'm trying to say? Okay. Instill hope. Right. Counselor, holder of hope. Right. Some cases, right? Some counselors will tell the students, I hope to see you tomorrow so that we can continue to work together. Okay? I'll leave it up to you to judge. There's no right or wrong. I want to see you and to continue to work with you. Even with adult, right? After you've done safety plan. Can I see you next Friday? We're going to discuss this, and I'm going to support you continue. You put that there so client has something to look for. If let's say client is highly suicidal. Okay? I have seen clients who respond very well with when you're ready, I'll give you back your hope. We hold the hope together. I want to continue to support you. As a counselor, I care about you. I want to continue to support you. I know this is very painful. I know this is very difficult for you. I'm not invalidating you. I'm here with you and walk this journey with you. I want to assure that space for him. You get my point? Counselors will do that. Right? You are instilling hope in a way. Okay? Exploring alternative. That action plan. Now, you construct an action plan, right? Depends on no suicide contract doesn't guarantee. So we don't do suicide contract, no suicide contract anymore. We do safety plan. Now this is safety plan, right? Warning thoughts. There are many different ones. Warnings or crisis, you identify it. People that I can call for help, you identify it. Ways that support, ways that will support people that can help me stay safe. How to help them stay safe? They write it down. I can tell this. I can call this very important phone number. You put it down. Hotlines maybe. I have great strength to help me get by, and then you help her to identify the strength. And activities I can do by myself to try to take my mind off things. Be it that is distracting, be it that is you are regulating, whatever client is coping at that point, healthy or not healthy, is to keep client alive. Because some counselors or some mental professionals, we are very quick, this is not healthy. But if let's say this is keeping clients alive at that point, that is what is very important. Unless you feel clients have the capacity to build different skills and to gear towards a direction what you would evaluate as healthy. So just now what I said, healthy and not healthy, the bottom line is if their sense of safety and safety of others is affected, then we have to go to the safety of how they are coping. You get what I'm trying to say? Yes, we try not to label because client will feel shame, client will feel that. But the bottom line is that, like what you say, alcohol, right? And what it will increase the likelihood of suicide accidents. Or you end your life by accidents. You drink a lot and you take medicine because you become so high, right? And then you did not have the intention, but you carry it out. because you are in the state of, not in the state of mind. So we will talk about that and discuss that. But that is the ideal. Let's say you discuss everything already, right? Client no friend, no nothing, very limited protective factors, and coping skills, okay lah, one or two. You can expand on those coping skills, right? But drinking is one of them. There's so many resources you are working around now, right? Then you are deciding, are you zooming in there? And how is that? You have to gauge of that safety of the coping, an impression of it, or maybe you can ask some question. Let's say client is telling you that, okay, that I usually do drink. I drink like 6 bottles, that's it. Right? But I don't take any other form of substance with it. Then you have to evaluate and decide according to your modalities and your own framework and your own decision making process. If you were to, okay, because that's how client knows now. There's so much of how during the first session, this is how much I know. Right? Is then you have a decision to make, right? Do I want to go in there and focus and zoom in about the alcohol at that point? Or is it more important to keep client alive first, as long as this is not affecting client safety? But will that increase the opportunity and the chances that from safety, now you evaluate become not safety? You have to evaluate that. And there's no straightforward answer. Yeah, and because if I say there's a textbook answer, it's not fair to the therapist, it's not fair to the clients. I have seen cases that are so complicated where keeping alive, nothing else. Client has to be alive first before anything else. Yeah. Then could also discuss the implication. Let's say client is taking drugs to keep alive, right? Then we discuss the implication of it, the safety of it, and negotiate with client. If you really take, right, how strategy manage. Because sometimes client will tell you that I also lock those things in. I cannot take it. I cannot read it. Then I will do that. Then you also have to think about it. Do I have to refer to an addiction counselor? Referral maybe is needed as well. Yeah, priorities. So if your client's sense of safety is affected, right, means keeping alive is the most important thing, then maybe that will be your focus. Because you cannot do everything else. Like even you extend until 3 hours or so, not possible. And 1.5 with all everything covered. Okay, should be in writing, safety plan. And then once you've done the safety plan, right, you have to send one copy to your clients to put at a place where your clients can notice it. And one copy you keep it. And why? Because your clients has to be reminded when they are triggered. The safety plan is supposed to help them to remind. Some clients will take picture. Now, I have 1 million question again. But if your client don't have any protective factor and ask, hey, Xing, can I put your name and your number as one of the person to call to? What if? For minor, the answer is no. For minor, the answer is what if for adult? The answer is also no. Type of follow-up depends on the degree of risk. For school, for societal cases, we see the student for 3 times a week. But 1 2-hour session, 2 other check-in for 5 to 10 minutes check-in. Now, for some schools, they will tell me, JK, you have to see these students every day, 5 to 10 minutes before the student go to class. Because they want us to have an impression of whether the student is functioning well that day or not. And I have met students come in, right? Memang tak boleh, memang tak okay. Highly suicidal. Now, the school is worried about what? The school is worried the student will carry out the plan in school. And it happened. So every time it happens, they put a net. You can see they want to block and they want to be careful, right? And so the implication is different there. And now, sometimes I say, school counselor also act like a social worker. We have the elements there because we are working in the community. But for adult, not necessarily. Mostly for high risk clients, we see once a week. Okay. Some clients might request for 2 twice a week. It depends on your justification and your clinical decisions. Okay, monitor ongoing risk funneling. Counselor have to assess the intervention strategy, and that's it for today. Let me quick. Sorry. So risk assessment has to be done continuously, and you will know when to prompt and when to go in deeper. Why I ask this, right? Because risk can escalate. Let me get back to this story later. Be aware and manage your attitude and reaction to suicide. Develop and maintain collaborative, empathic stand with clients. Know, elicit evidence-based risk and protective factors. Ask clients about individual factors that reduce intent if you want to. Explore strength-based, explore their strength. Okay, collaborate with clients to better understand factors that increase and decrease the individual risk. Again, you are looking at risk factors and protective factors. You are identifying them and expanding them. And this one, to develop and enact a collaborative evidence-based treatment plan. Okay, and establishing an individualized safety plan and to include positive coping skills and holistic treatment plan. Usually, you won't be able to draft the holistic treatment plan in the first few sessions and everything because it's just too much, right? You will, as you move along the way, you will be able to develop that. Notify and involve people. And document risk assessment, yeah, this is very, very important. The treatment plan and the rationale for clinical decision. And know the law about your setting, about workplace, about society in Malaysia, and engage in debriefing and self-care. So self-care is very, very important. I cannot emphasize that enough. Self-care is super, super, super important, especially when you are supporting clients with suicide, high risk, and yeah. So please do take care of yourself.